دكتور هاني راجي فين؟ دكتور هاني راجي انت المودريتور بتاع السيشن اللي جايه ديت. اتفضل بقى. ومعانا الدكتور عاطف البحري تشير بيرسون والدكتور هاني راجي مودريتور. دكتور حازم خميس طبعا كالعاده غالبا في حد اتزنق في مسؤول مهم دخل وادي النيل ولا حاجه.
Okay, I'd like to introduce
دكتور احمد الغليظ. اتفضل على الجلسه لو سمحت.
It's my pleasure to introduce my dear friend, Professor Ashraf Reda, the NAFLD Basics and Risk of Cardiovascular Disease. موضوع حلو جدا دكتور هاني ان انت ايه لان ده بتاع الساعه دلوقتي.
ثانك يو دكتور عاطف. الحقيقه الدكتور هاني راجي هو اللي اقترح الموضوع ده من فتره. الفاتي ليفر non alcoholic fatty liver disease and the first we think that this is away from us as a cardiologist or preventive lipidologist, but we will try in these sessions to tell you how close is this disease to our clinical practice. First of all, I have to thank many thanks to the webinar of the European Atherosclerosis Society about this important disease, and actually my presentation is based in many parts on parts of this webinar. So, non-alcoholic fatty liver disease, actually it is a spectrum of fat-associated liver disease. Starting with the risk factor, bad lifestyle, obesity, and genetic predisposition. You may have at first some steatosis. 10 to 30% of those patients with the steatosis will develop NASH. NASH means steatohepatitis, non-alcoholic steatohepatitis. This may be accompanied by fibrosis or not. 2% of those with hepatitis will develop cirrhosis. And unfortunately, 1 to 4% of this patient per year may develop hepatocellular carcinoma. So, as you see, non-alcoholic fatty liver disease is a spectrum of disease that associated the liver. However, it is not only affecting the liver. It is really a multi-system disease that its effect is much more beyond the liver. It can lead to cardiovascular disease and arrhythmia, type 2 diabetes. It can lead to chronic kidney disease, and it can lead to colorectal cancers. How this happens? This happens through many mechanisms. Insulin resistance and hyperinsulinemia, the release of vasoactive and thrombogenic molecules from the inflammation in the liver, and the pro-inflammatory factors like interleukin and 1 and 6 and tumor necrosis factor. Actually, we have evidence that this fatty liver disease can increase the risk of many important diseases. For example, this meta-analysis of updated in 2020, including 33 studies, showed the association of fatty liver disease with incident diabetes. And in summary, the 2.2 actually the hazard ratio of this association. Not only incident diabetes, but also the incidence of cardiovascular disease event, whether fatal or non-fatal or both. And actually, this is also an important meta-analysis, showing a hazard ratio of 1.6. So now we have incident diabetes, we have incidence cardiovascular disease event association, and we have also chronic kidney disease association with patients with non-alcoholic fatty liver disease with a hazard ratio of 1.4. So actually, if we look at two important diseases and the relation between them, non-alcoholic fatty liver disease on one hand and type 2 diabetes in one hand. Both of them are related to cardiovascular disease and chronic kidney disease. And both of them aggravate each other. And as I told you, unfortunately, this may end with hepatocellular carcinoma. So type 2 diabetes, metabolic syndrome can lead to non-alcoholic fatty liver disease. And non-alcoholic fatty liver disease, by its effect on the liver, effect on pancreas, and insulin resistance can lead to type 2 diabetes. So metabolic syndrome and type 2 diabetes are closely associated with non-alcoholic fatty liver disease and are important risk factor for this disease and its progression. This may be due to what happened inside the liver with a patient in metabolic syndrome and type 2 disease. You will have insulin resistance. You have metabolic syndrome in patient with metabolic syndrome features. You have risk factor for cardiovascular disease, and you have genetic predisposition. So actually, as you know, patients with metabolic syndrome are liable to insulin resistance, liable to type 2 diabetes because of beta cell dysfunction. What happened in the liver and outside the liver in fatty liver disease? Actually, inside the liver, you may have increased formation of triglycerides, increased triglyceride load inside the liver that leads to high percentage of VLDL assembly release in the blood, increased VLDL synthesis, and as you know, the important link between VLDL, triglycerides, and cardiovascular disease. Also, in patients with metabolic syndrome with activated adipose tissue, and these triglyceride affections with pro-inflammatory cytokines and decreased adiponectin can lead to a secondary effect inside the liver. So you have hepatic inflammation, you have hepatic insulin resistance, you have increased lipogenesis, and this may lead to increased hepatic glucose output. All of these, or most of these effects are due to the release of vasoactive and thrombogenic molecules from the liver, like fibrinogen, transforming growth factor beta, plasminogen activator inhibitor 1. Also, not only vasoactive and thrombogenic, but also release of pro-inflammatory factor like interleukin 1 and the beta, interleukin 6, tumor necrosis factors, and others. And as you know, there is an important link between VLDL cholesterol and cardiovascular risk. Obesity associated actually with higher VLDL cholesterol concentration. And this, as we know, I mean, from many observational data and studies, associated with increased myocardial infarction and atherosclerotic cardiovascular disease. The high cholesterol concentration of VLDL and IDL, intermediate density lipoprotein, in addition to LDL, is a risk factor for cardiovascular disease. So the question is, does VLDL cholesterol explain a fraction of the excess risk of myocardial infarction in obesity? There is a lot of data that those with obesity are liable to myocardial infarction than non-obese persons. Is this related mainly to VLDL and VLDL cholesterol? Actually, VLDL cholesterol may mediate a substantial component of the cardiovascular disease risk in obesity. And this is results of a study of nearly 30,000 adults at baseline nested with 109 in 1,000 individuals, and this is from the Copenhagen General Population Study. It includes 10 years of follow-up with around 2,306 individuals developed myocardial infarction, and the cholesterol content, large and small VLDL, IDL and LDL measured by specific measurement spectroscopy, and it is very clear from this observational data that the baseline, and this is the baseline characteristics by weight characteristics according to the body mass index, and as you know here, the total triglycerides and the relation to the obesity, overweight, normal weight, and underweight person. So actually, those obese patients has active fat cells, has insulin resistance, has a lot of fat burden in the liver. By the end of the day, a lot of VLDL cholesterol in the bloodstream, and the triglyceride-rich lipoproteins. We know it's important link with inflammation, with atherosclerosis. So actually, liver, atherosclerosis, diabetes are, there is continuous crosstalk in our blood between these three important systems in our body. This is a percentage of excess risk of myocardial infarction from obesity individuals. And if you notice, this cholesterol, the relations was more with cholesterol in large and small VLDL combined together if we compared it with other parameters like cholesterol in the IDL or in the LDL. So the correlations with VLDL is there with myocardial infarction and with cardiovascular events. There is genetic predisposition to the fatty liver disease. The response of individual response to fatty liver is not the same in all individuals, and these depend on some genetic variations, but it is related to lead by the end of the day to increase fatty liver, increase the risk of diabetes mellitus, and increase the risk of cardiovascular disease. So if we can summarize what happening you have modifying influence of some genetic factors that leads to triglyceride load in the liver, lead to production of VLDL cholesterol, and this lead to what we called atherogenic lipoprotein phenotype, characterized by high level of VLDL, low HDL level, and increased small density lipoproteins. In addition to this effect on lipid parameters, we have the inflammation, we have the insulin resistance, and we have the oxidative stress. These all can affect the adipose tissue, can affect the insulin resistance, can lead to type 2 diabetes and cardiovascular disease. I'll finish with a recall from one of the international experts in lipidology. I will not cover the treatment of these subjects. It will be covered later by Hani and Ahmed Bindari. The relation of statin to liver disease. Thomas Despering said in a Twitter that while early data depicted statin as harmful agent for the liver, current evidence from preclinical and the clinical study suggests that they might have positive impact even in chronic liver disease. And one of these is the statin liver. And he put these pictures and how statin can improve through many mechanisms, the nitric oxide, the decreased leukocytic recruitment, interleukin 6, decreased hepatic stellate cell activations and cell migration and the proliferation, and by the end of the way, they can decrease the fibrosis and even decrease the portal hypertension and the inflammatory response. So don't be afraid from statin in chronic liver disease, and thank you very much.
Thank you very much, Dr. Ashraf. And we'll allow one question.
Thank you, Professor Ashraf, for such an elegant presentation. And I'd like also to thank Professor Hani because he raising up this very important topic. And actually, when he told me about and told Professor Ashraf about this topic, I googled it and I found a striking data that 25% of the entire population have this problem. And imagine that we are looking for different abdominal ultrasonography, and we notice in the report that there is fatty liver. We think that it is an error. It is not right. But actually, it is true. 25% of the entire population have non-alcoholic fatty liver disease. And strikingly also, because I presented today the GLB receptor agonist, and I think it will be discussed by Professor Hani and Professor Bindari. It is one of the solutions, and the FibroScan was one of the diagnostic tools. Thank you.